Dr. Scott Brandman is a specialist in thoracic imaging. Dr. Brandman interprets chest radiographs, CT, and MRI examinations performed for pulmonary and cardiovascular diseases at Arizona Diagnostic Radiology. Please go ahead, Dr. Brandman.
Thank you for having me. In this session, we're going to take a look at the role of radiology in lung cancer screening and how you can partner with radiologists in your community to have a positive impact on patient outcomes. About 250,000 people in the US are diagnosed with lung cancer every year. In 2023, about 127,000 people died of lung cancer, making it the leading cause of cancer death. And that's nearly 3 times the number of deaths due to colorectal cancer, which is the second most common cause of cancer death. Next slide, please. So why is lung cancer so deadly? We have many excellent treatment options today, and they're extremely effective when the disease is found in an early stage. But unfortunately, almost half of them are not caught until a late stage when there's regional or distant spread of cancer. So sadly, more than half of people with lung cancer will die within 1 year of being diagnosed. By the time symptoms appear, it's often too late, as you can tell in these low 5-year survival rates for those with regional or distant disease. Next slide, please. And that's why screening for lung cancer is so important. For patients who participate in a lung cancer screening program, 70% of the detected lung cancers are early stage, when treatments are most effective. And that is so critically important because we recently learned that lung cancer patients diagnosed in an early stage have an overall 20-year survival rate of 80%. Next slide. And although the smoking prevalence has been showing a downward trend in the US, we still have 28% of adults currently smoking. So tobacco-related diseases such as lung cancer are expected to remain important health problems for decades to come. So how do you identify this 28% of your patient population, and which of them should be encouraged to enter a lung cancer screening program? Well, the US Preventative Services Task Force recommends screening for patients who are 50 to 80 years old, are currently smoking, or have smoked at some point in the last 15 years, and have at least a 20-pack year smoking history. And you calculate the pack years using the number of packs smoked per day when the patient was at their peak of being a full-time smoker. Next slide. Veterans are an important population likely to benefit substantially from lung cancer screening. Veterans have a higher smoking prevalence than non-veterans, and they have unique occupational exposures that may further increase their cancer risk. But the use of lung cancer screening among veterans today is skewed toward those in poorer health. And this could decrease the benefit of early lung cancer detection by exposing them to unnecessary harm because they're not healthy enough to undergo curative treatments. So it's important to highlight the need to promote lung cancer screening among healthier veterans who will benefit the most. There are also significant disparities between white and non-white veterans' rate of participation in screening. This is so important for us to address because the non-white veterans who are less likely to be screened are the ones who have the greatest screening mortality benefit. So this really emphasizes the need to reach healthier veterans, especially non-white veterans who are appropriate candidates for screening. Next slide, please. There are no current guidelines recommending lung cancer screening in firefighters who may develop lung cancer from their occupational exposures. But we know that occupational exposures account for about 30% of lung cancer cases. Researchers have found that even at fires with low smoke intensity, firefighters are exposed to significant levels of toxic materials, including carbon monoxide, benzene, aldehydes, and hydrogen cyanide. And studies have shown that firefighters have higher rates than the general population for many cancer types. Unfortunately, the longer they're on the job, the greater their risk. So I've been interpreting low-dose chest CTs on asymptomatic firefighters and working with Dr. Vershali Shukla at the Vincere Cancer Center in Scottsdale, Arizona, to learn the value of lung cancer screening in this population. And we're now working to increase the scale of the study and to start interpreting the second round of annual follow-up exams. And we look forward to the results, and we hope to impact current guidelines for screening in the future. Next slide, please. Although it's well known that smoking tobacco can lead to the development of lung cancer, many people ask if vaping can cause lung cancer. Since vaping and the use of e-cigarettes are a relatively new phenomenon, the simple answer is that no one yet knows what the long-term effects may be. So researchers are still working to determine if vaping increases a person's risk of developing lung cancer. And it may be some time before we get the answer, because if we extrapolate from tobacco smoke data, it could take 20 years for a cancer to develop. With that being said, many of these products contain dangerous chemicals that have previously been associated with a higher risk of lung cancer, including formaldehyde. So there's clear reason for concern here based on just basic and molecular science. But for the time being, this is not included in the current guidelines for lung cancer screening, yet it may have significant future implications for public health. Similarly, patients with a family history of lung cancer are not yet included in the USPSTF recommendations for screening, yet research has shown that these patients are at 2 to 5 times increased risk for lung cancer, even if they are non-smokers. So we are certain to see recommendations continue to evolve as we move into the future. Next slide, please. Now, once you have identified a currently eligible patient, you can share good news with them because screening for lung cancer is a covered insurance benefit with no out-of-pocket expenses. Medicare covers lung cancer screening for those 50 to 77 years old, and commercial insurance and Medicaid expansion plans cover it for those 50 to 80 years old. But if a patient's health plan was in place before the Affordable Care Act was passed, then it may not offer the same coverage, so it's important for patients to check their plan documents. Next slide. And there's compensation available for you as the provider for taking the time to identify these patients. For example, CMS pays about $29 for completing eligibility determination for lung cancer screening and shared decision-making. Next slide. And CMS recognizes the importance of smoking cessation counseling that you can offer separately to your patients. It reimburses about $18 for an intermediate level of counseling and about $30 for intensive counseling. Next slide, please. So for patients who may express concern to you about having the test done, you can offer them reassurance on several fronts. First, there are no needles or injections, so that means there's no contrast administered, and therefore there's no need for recent blood work. Second, there's no feeling of claustrophobia because CT machines don't have a long tunnel. And the required breath hold for most machines today is only up to about 10 seconds. Also, there's no fasting needed prior to the exam. Next slide, please. It's also useful to reassure patients who express concern regarding radiation exposure. Lung cancer screening uses a low-dose CT scan. So running this exam on a piece of modern equipment will result in a radiation dose to the patient of 0.7 to 1 millisievert, depending on the patient's weight. So rather than going into the physics of what that means, it's useful to put it into context. Depending on the elevation of your hometown, you receive anywhere from 3 to 5 millisieverts in annual natural background radiation each year. If you fly on a commercial airliner, you're exposed to more radiation than when you're on land, and the amount of radiation received during a low-dose CT is similar to 5 round-trip flights between Los Angeles and London. So researchers have looked at the data and found that over the course of a patient's participation in a screening program, there's a lifetime radiation-induced risk of 0.05% for men and 0.09% for women. That corresponds to one radiation-induced cancer per 2,500 patients screened. So in terms of a population screening program, this risk is seen as extremely low. Next slide, please. With all of that reassurance, I hope that everyone listening can help identify candidates for screening, because last year, Florida, for example, only screened 2.4% of its high-risk patients. I know that we have some people joining us today from my neck of the woods in Arizona, where 1.3% of high-risk patients were screened last year. And for those of you in Texas, it was 1.2%. And unfortunately, for those of you in California, we saw the worst uptake in the nation with only 0.7% of eligible patients screened. The national rate is also low at 4.5%. But I hope you can take this information back to your practices and make a positive impact on the community by identifying and referring eligible patients for screening. Next slide, please. For those of you who have referred patients for lung cancer screening, you're aware that the result you receive follows a standardized reporting system. When the idea of lung cancer screening was being developed, there was concern about overtesting, radiation exposure, anxiety, the use of invasive procedures, and cost. So we needed a system to standardize our reporting and management of screening results, and a way to facilitate tracking of patient data. From this need, the standardized reporting system called LungRads was developed by the American College of Radiology. Next slide, please. LungRads has evolved over time, and the newest revision was released at the end of 2022. Each lung cancer screening exam is assigned a single category that is based on the most suspicious finding. The system takes into consideration the size of a nodule, change in size over time, and its composition to determine the assigned category. And with that assigned category, a management recommendation will be made by the radiologist to help guide your work with the patient. For categories 1 and 2, negative and benign, there will be a recommendation for the patient to return in 12 months for a repeat annual screening low-dose CT. For category 3, probably benign, there will be a recommendation for the patient to return in 6 months for a diagnostic low-dose CT. For category 4A, suspicious, the radiologist will recommend either a follow-up diagnostic low-dose CT in 3 months or a PET CT in some situations. And for categories 4B and 4X, the radiologist will recommend either a PET CT, tissue sampling, or referral for consultation with pulmonology. Next slide, please. Now, a question that often comes up is, how do you order these things? So a patient who presents for their initial baseline screening CT exam needs an order for an annual screening exam. That is a CT chest low dose for lung cancer screening without contrast that has code CPT 71271. A patient who previously had their baseline screening CT and received a recommendation to return in 12 months for annual follow-up, that patient also needs an order for an annual screening exam. So again, a CT chest low dose for lung cancer screening without contrast, CPT 71271. Now, any patient who previously had a screening exam and received a recommendation for a short-term follow-up CT at 1 month, 3 months, or 6 months, those patients need an order for a diagnostic low-dose CT, that is a chest CT without contrast using low-dose technique, CPT 71250. Next slide. So here is an example of a patient with a non-solid nodule that was just over 30 millimeter on the baseline exam. It's scored as a LungRads 3, probably benign, with a recommendation to follow up in 6 months with a diagnostic low-dose CT. The reason for the follow-up is to see if the nodule disappears, which would mean that it was infectious or inflammatory. But here on the right, for the 6-month follow-up, the nodule persists and is stable in appearance. So this is probably adenocarcinoma in situ without invasion that isn't going to harm the patient at this time, but needs to be monitored for the development of invasion, which would show up on the CT as a solid component to the nodule. So this nodule is now downgraded to a category 2 benign on the 6-month follow-up exam, and the patient can then return to annual screening with a screening low-dose CT in 12 months. Next slide, please. Here's another case. It has a solid nodule found on a baseline screening exam. It's 13 millimeters in mean diameter, and based on that size, it's classified as lung RADS 4A, suspicious. So the management options are to do a 3-month follow-up diagnostic low-dose CT or to evaluate with PET-CT. The provider for this patient ordered a PET-CT, and it did not show significant radiotracer uptake. Then a follow-up low-dose diagnostic CT in 3 months showed the nodule to be stable in size. So it's now downgraded to lung RADS category 3, probably benign, with a recommendation to repeat a low-dose diagnostic CT in 6 months. Next slide, please. Here is a case where a patient underwent baseline screening and there were no nodules. The exam was scored as a lung RADS category 1 negative. The patient was reminded to return 12 months later for another annual screening low-dose CT, and a 12 millimeter solid nodule developed. The fact that it's a new nodule, and based on its size, it is classified as lung RADS 4B, very suspicious. The management options here are PET-CT or tissue sampling. The provider for this patient chose to refer them to an interventional pulmonologist who performed a biopsy by robotic-assisted navigational bronchoscopy, and it turned out to be a small cell lung cancer. Next slide, please. Now, here's an example that I would like to share with you because it illustrates the value of encouraging patients to comply with the radiologist's follow-up recommendations. Here, there's a non-solid nodule on baseline screening that was just over 30 millimeter. It's assigned to lung RADS category 3, probably benign, and the follow-up recommendation is a low-dose diagnostic CT in 6 months. On the 6-month follow-up exam, the nodule is essentially stable, so it's downgraded to a lung RADS category 2 benign, and the recommendation is to resume annual screening with low-dose CT. The patient then comes back 12 months later, and the nodule has become part solid. It now has a new solid component and is therefore reassigned to lung RADS category 4B, very suspicious. And now the management recommendation depends on the clinical picture and the patient's preference. We can evaluate this nodule with PET-CT, or we can do tissue sampling, or we can refer for a pulmonology consult. This turned out to be a case of invasive adenocarcinoma in situ that had a curative resection. And if the patient was lost to follow-up along this timeline, then we probably would not have found this until it progressed to a later stage. Next slide. So I would really like to emphasize the importance of performing the recommended follow-up exams. In fact, the mortality benefit that is associated with lung cancer screening requires a high adherence to follow-up. In the National Lung Cancer Screening Trial, where much of our landmark knowledge and experience with screening comes from, nearly 60% of lung cancers in the intervention group were detected during the 2nd and 3rd rounds of screening. So it's important to remember that helping patients adhere to follow-up recommendations will allow you to identify lung cancer at an earlier stage and improve outcomes. A meta-analysis found a pretty low adherence rate in clinical practice of only 55%, but thankfully all of you now have this valuable knowledge and will work to have an adherence rate in your practice that is much higher. Next slide. Often there will be incidental findings on exams done for lung cancer screening. The prevalence varies between university and community-based radiology practices, and gender also plays a role, but a university-based screening program will find an incidental finding in about 60% of patients. The most common finding is coronary artery calcification. It's very important for radiologists to report the severity of coronary artery calcification because it corresponds strongly with cardiac risk, and the information will often impact treatment strategies. This has been shown to improve cost efficacy and health outcomes. For some of the incidental findings, though, the clinical benefit of reporting them is uncertain. To help mitigate the unnecessary investigation of clinically unimportant incidental findings, the American College of Radiology gives radiologists guidelines on how to manage them. And this guidance is then passed on to the primary care providers so that we're not chasing after things that don't have any clinical benefit. Next slide. Some radiology groups today are using computer-aided detection to help them find and measure lung nodules. It's a useful tool to help reduce false negative results and to measure changes in nodule size over time. This is something that works alongside the radiologist. Each nodule finding is verified by the radiologist. Next slide. And on the horizon are revolutionary artificial intelligence systems that can see and detect things that we can't with the human eye. These AI algorithms are still difficult to create today, and there are challenges to validating them because the data that you use to train the system has to be so carefully curated. But efforts on this front will have great benefits for lung cancer screening in many ways. For example, it can take in and process clinical data about each patient to create a personalized risk assessment and optimize who is eligible for screening rather than using the sweeping generalizations that we use today. It can help us with image acquisition by adjusting the CT technique for each patient in a way that maintains image quality but reduces radiation exposure even more than we've done today. There will be AI-based systems for automated nodule detection to reduce the manual workload that we have today and eliminating false negatives. And most importantly, it will provide characterization of nodules as benign or malignant so that unnecessary biopsies or surgeries are avoided. Next slide. Now, differentiating benign from malignant nodules on CT with an AI system has the potential to help us decrease the number of unnecessary follow-up scans and biopsies on patients with nodules that are low risk. There's one model today, for example, that reduces the false positive rate on a baseline screening exam from 14% with a human reader down to 8%, while still maintaining a high level of sensitivity for lung cancer. So AI may be, and in some cases already is, more accurate than a radiologist. And that is why pursuing this technology as it applies to medical imaging is worthwhile. So that's our look into the future. Thank you for your interest in lung cancer screening. I hope you've gained some useful information to make you an even more successful partner in lung cancer screening. So please remember, check in with your patients and help keep them on track with recommended follow-up exams.
Thank you, Dr. Brandman.